Okay. Thank you, guys. Can everybody hear me okay? Okay. All right, so thank you for having me here today. So I am here to talk to you guys about a value-based purchasing program that impacts clinicians in the Medicare space, specifically clinicians who are rendering outpatient services. So I'm going to go through all the details and what this is and why you guys should care about it. If you have questions, because there is a lot of information I'm going to be covering, feel free to stop me throughout. So let's go ahead and dive right in. So the pieces I'm going to cover today, why I'm here, what the authorizing legislation was, what is the quality payment program, how it impacts you, how you can participate, all of that fun stuff. So first, to start with, why am I here? Why should you guys care about this? So again, I work at Medicare in the Center for Clinical Standards and Quality, and so we oversee a number of value-based purchasing programs. So again, when we think about value-based care, it's really ensuring that patients are receiving high quality with cost control, also taking into consideration their patient experience. So there's a number of value-based purchasing programs that CMS is implementing. They span across really all care settings. We have a number of hospital-based programs. We have programs that exist in the post-acute space. We also have the program that I'm going to be talking about today, which impacts clinicians, again, who render services under Part B, which is typically outpatient services. So what happened a few years ago? So a few years ago, Congress passed a law, yay for them. It was the MACRA, the Medicare Access and CHIP Reauthorization Act. And so it was a bipartisan effort, and it did a handful of things. First, it repealed the sustainable growth rate methodology, which I think some of you guys are familiar with. So the SGR methodology, it was put in place a few decades ago, and it was supposed to account for changes in spending over time. But what actually ended up happening over the past decade or so was that if the SGR methodology would have went into effect the way that the law was written, there would have been considerable reductions in payments that we, Medicare, would reimburse clinicians on. So there was an annual doc fix that Congress would pass every year. So when MACRA passed 4 years ago, they got away with the SGR methodology, and now there's flat fee schedule updates. When I talk about the fee schedule, I mean the physician fee schedule. It also ended 3 legacy quality reporting programs. So in the Medicare space, we talk about value-based purchasing programs and quality reporting programs. So value-based purchasing programs, again, are when we're looking at quality and cost, taking into consideration patient experience, but really looking at how clinicians are performing on those actions. A quality reporting program also takes those into consideration, but looks less on the actual performance, but more on just whether or not you as a clinician did the specific measures and activities for your patient, so whether you actually reported that you could have done these. So it ended a couple reporting programs, which included the Physician Quality Reporting System, or PQRS program, the Medicare EHR incentive program, which deals with the use of implementing electronic health records. You'll hear me talk about it here today as CERT, Certified EHR Technology, which our colleagues over at the Office of the National Coordinator, they certify EHR products. And it also ended a value-based purchasing program which impacted docs, the physician value modifier. That program just looked at the assessment of quality and cost. And so all 3 of those programs had separate authorizing legislations. So again, what we do at Medicare is based off of what Congress tells us to do. So when a law passes, it tells us, Medicare, these are the certain things that you have to do. And so while we tried to do the best that we could of aligning those requirements to reduce administrative burden, we know that there's a lot that you all clinicians are being asked to do of not only caring for your patients, but also a lot of administrative activities. So while we tried to align those programs as much as we could, there were still differences that we couldn't account for. So again, when MACRA passed a few years ago, it ended those programs, and it authorized the Quality Payment Program, which is the project that I work on. I think I already talked about SGR. So with the Quality Payment Program, there's two tracks. There's the MIPS track and then the Advanced Alternative Payment Model track. So MIPS is what I'm going to be talking about here today. So MIPS is a program that assesses your performance on 4 different performance areas. Alternative payment models, so these are different ways that we can reimburse you all, and it typically involves quality, cost, but also accepting higher risk. So I won't be talking about APMs today. If you guys have questions on that, feel free to ask, and I can take them back to my colleagues back at CMS. We have a number of APMs that we have currently available, and we're working on rolling out more APMs. But the overall goals of the Quality Payment Program, as I have on this slide here, are that we want to, first and foremost, improve beneficiary outcomes, so improve patient outcomes, which I know is something all of you want to do as well. We really want to have healthier patients. We also, as I talked about earlier, really want to reduce burden on clinicians. And when you think about some of the things that this administration has done, some of our different initiatives, patients over paperwork, meaningful measures, all of those are really focused on ensuring that patients are receiving the right care at the right time and are trying to reduce these really burdensome regulations, these administrative actions that we've had you do in the past. One of the other main areas that we've spent a lot of time focusing on is, again, when you think about the Quality Payment Program, as I have back on this slide here, there's the 2 tracks, MIPS and APMs. We ideally would like to see as many clinicians as it makes sense for them to join an APM, because again, that means that you're really focusing on population-based care, care coordination, and accepting higher risk. We recognize that that may not make sense for every single clinician, but ideally we want to start seeing more and more clinicians being able to join an APM in the near future. We have a number of other strategic objectives that we have as part of the program, really ensuring that in all the ways that you interact with us is in a manner that really ensures excellence. Okay, so those are the basics. That's why I'm here. That's how the law passed. And so let's dig into the MIPS program. So I'm going to be talking about a number of things, and there's a number of key terms that I will be tossing around, so I want to make sure that you guys are tracking to what these mean. So when I talk about a clinician under MIPS, we define clinicians, and when I say a clinician, that includes a physician, a nurse practitioner, physician assistant, clinical nurse specialist. It also includes physical therapists, occupational therapists. I have a coming slide which lists all of those. But when we talk about clinicians, we define you all based off of your unique TIN NPI combination. So your TIN is your tax identification number. Your NPI is your national provider identifier. And this is important because, again, we base it off of that unique combination. So if you, when you're practicing medicine, if you are doing that at multiple clinics, you could have multiple tax identification numbers associated with you. So again, if Dr. Molly, if I'm working at Hopkins in Baltimore, but then I also work at University of Maryland, also in Baltimore, I would, in all instances, have 2 separate tax identification numbers. The way that the program, the MIPS program, would view me is as 2 separate clinicians. And so then for each of those separate 10 MPI combinations, I would have to be eligible and meet the performance requirements. I'll go over all of that. I also will be talking about our years that the program relates to. So again, MACRA, the law, passed in 2015. The law told us that the first year that payment adjustments had to be updated was this calendar year, 2019, which means the first year of performance was back in 2017. So you'll see that happening for the next few years. So right now in calendar year 2019, that is our performance year, it will impact payments in 2021. This corresponding adjustment column, this refers to the amount that your physician fee schedule reimbursements could either get a positive increase or a negative reduction. So the program, the end result is that there will be a money impact. So if you are a high performer, you can get more money on your claims that you submit to Medicare for reimbursement. If you are not a high performer, you would get a reduction in your claims. Again, I'll be talking through all of this. So for the MIPS program, we assess your performance on 4 separate performance categories. The first is quality, so quality measurement. We have over 250 quality measures that you can select from. There's cost, so cost performance. We have measures that we assess on your behalf. Improvement activities, this deals with internal quality improvements you would make as part of your organization. And then promoting interoperability deals with the usage of certified EHR technology. And so as you can see that each of these 4 performance categories has numbers or weight associated with that. All of those roll up to 100 points. And that becomes important because what we do under MIPS is we assess your performance on these 4 performance categories, and your performance can range anywhere between 0 and 100 points. Based off of how you perform, you would get a final score, and depending upon where that final score relates to a performance threshold, that will determine whether or not you get more money or less money on your claims. So for this year, for the 3rd year, calendar year 19, the number that I want you guys to remember is 30. So that's our performance threshold. So that is where ideally everyone's performance should be at or above. Because what macro the law tells us to do, again, is to assess your performance on these 4 areas, give to each clinician a final score, and then how that final score relates to that performance threshold will determine whether you get more or less money. Another thing that I want to make sure you guys are tracking to is that the MIPS program, again, as required by law, it must be implemented in a budget-neutral manner. So what that means is that the total amount of money we can give to the top performers, so the positive reimbursement, so the bonus, will be offset by the total amount of money we would be receiving from the negative adjustments. So essentially the total number of winners and losers has to be equal. So again, when we have back on this slide here, the corresponding adjustment, so looking at the bottom row, so for this year, the total amount of adjustments can go up to 7%, subject to a scaling factor to ensure budget neutrality. So what that means is that if we have a large number of people receiving really high scores, then the total amount of money we could distribute may not be up to 7%. It could be something lower than that. It could be 2 or 3%, depending upon what people's scores are. However, if we have a lot of people receiving final scores that are below that performance threshold 30, so if we have a lot of people receiving the negative adjustment, then the total number of winners would be fewer, which means we could conceivably give adjustments higher than 7%. Any questions on that before I move on? I realize it can be a bit complicated. Yeah. We have, so we're past our first year, so we already are implementing adjustments on clinicians' claims for the 2019 year. And for the first year, it was up to 4%. We had a large number of folks who were well above the performance threshold. We set it at a really low number because we really wanted to get as many people participating as possible. So I think the maximum adjustments in the first year were around right under 2%. But as you can see, we could have gone up to 4%, but since we didn't have very many losers and we had so many winners, that's why we resulted in that lower than 4% distribution. So each year is a separate set of things that you have to do, and so a separate opportunity to either score really well or score really low. So how you performed in the first year, so if you are one of the people who got the top final score, you got a 100-point final score, you're getting the maximum adjustment of right under 2%. If in the second year, let's say you phone it in, you just forget to do what you're supposed to do, which I don't think any of you guys would be doing. But let's say if, for example, that happened and your final score was 0 points, then you would be getting in the second year the negative 5% adjustment. Then, if in this third year you participate, you do everything you're supposed to do, you get a maximum final score, you then again could be getting the positive adjustment. So how you perform year over year, it is a separate assessment. The one thing I will note, and I'll talk about this a little bit later on in more detail, is by law, for the quality performance category, we do have to account for how you are improving year over year. So we ask you to do certain things each year, and we will be assessing how you're performing on an annual basis, but then we also will be looking to see how you are improving on that. So if, for example, in the first year you scored really low on quality, in the second year you scored really high on quality, the way that we calculate your improvement score is that we account for higher rates of improvement. So there is a portion of that baked in. We also have to do that in cost, but Congress has given us until year 6 to start implementing that improvement for cost. Okay, let me go ahead and keep moving on. If you guys have other questions, feel free to stop me throughout. Again, I realize this is a lot of information to cover and it can get really technical really quickly. Typically what we try to do is, so we go through the way that Medicare, we say these are the things that we have to do. We go through the rulemaking process. So this last year we have entered our policies into the physician fee schedule rule. You, of course, don't have to read all of that. It gets really technical. I know you guys have societies. You have SMA who helps you with all of that. But we do have on our website, which I'll just share with you guys now, it's qpp.cms.gov. We have a lot of fact sheets out there. We have a lot of information. We also have a lot of tools on that website that we've created by working with a number of clinicians to ensure that it makes sense. So again, happy to talk through all of that as well. But anyways, I guess the point I was trying to make is that the process that we have is that we implement all of our policies and we try to establish all of our scoring rules before the performance period begins. We really want to make sure that you guys know what is expected of you prior to the performance period beginning. There are some instances where we have to update measures or measure benchmarks. Maybe that's what you were referring to. If there has been a clinical guideline change, so if, for example, we have a quality measure and if a new guideline comes out that tells us that the current measure would result in patient harm, or if we determine that the way that we create our benchmark, if it wasn't calculated accurately, then those would be kind of the rare instances where we would have to update those benchmarks or suppress a measure. So that could be what you were talking about, but we can still talk about it afterwards if you have time. Okay, so then the general timeline of what you guys would have to do is, and again, this repeats itself every year, but just focusing on for this year. So the performance period is calendar year 19. So that is when you guys should be performing under those 4 performance categories: quality, cost, improvement activities, and promoting interoperability. I'll go into the details of what you have to do in each of those in coming slides. Then the majority of the data will get submitted to us, CMS, in the following calendar quarter, so from around January through the end of March 2020. Then we issue feedback, which tells you based off of those 4 performance categories, how you performed, and then also what your final score is. We also include in that feedback what your estimated payment adjustment percentage can be. Then after that feedback is released, if for any reason you have concerns with your final score, your payment adjustment percentage, we do have the ability for you to submit a targeted review. Essentially, it's an appeal if you think that there is an error in our calculations or anything that we've received. And then the adjustments go into effect calendar year 2021. Again, these would go on a per claim basis for your Part B services. And it would be, again, either a upwards adjustment, which in this third year could be up to 7%, or a negative adjustment of -7% per claim. The performance period, so again, you'll be seeing your patients when you select your quality measures depending upon what your specialty is. So let's say you're focused on, primary care. So we have a number of primary care measures. We have measures that deal with BMI, medication reconciliation, smoking cessation. So let's say you pick, those are some of the measures that you select. During the performance period, again, just picking on smoking cessation because it's an easy one. Every single patient that comes in that meets the denominator of the measure, and the denominator spells out specifically, this is the age range of the patient population you should be assessing it for, the eligibility code, so the E&M codes, as well as the diagnosis codes that you should be assessing the patient on. So that just determines, okay, I, Dr. Molly, had a patient who came in that I should be giving them smoking cessation counseling on. Then, as part of the quality action associated with the measure, it's broken down into whether or not you actually gave them smoking cessation counseling, whether you didn't do that, and it could be that you don't have to due to a system or patient reason, or it could be that you just didn't do it. And so that happens during the performance period. So you would be doing that for every patient that is eligible during this year. And you would still submit your claims as normal for seeing those patients. Then, once we get all that data in, we'll calculate your performance on all of those measures. Again, give you that final score, figure out how much your payment adjustment percentage would be. That would then be applied on your claims that you render in 2021 for all of your patients, regardless of whether or not they would be applicable to a given measure. Does that make sense? Okay, let me keep going. Again, feel free to stop me. Key resources, I will be talking about this a lot. If you guys haven't gone to our website, I do encourage you to do so. One of the main reasons is, one, and I take this as a compliment, it doesn't look like a normal government website. We've actually tried really hard to make the information as user-friendly as possible. We actually engage a lot of user experience testing with, again, frontline clinicians, with many of you guys, to make sure that all the information that we are sharing actually makes sense. It's something that we don't necessarily do that great in the government, so we've really tried to change that. So I'll be talking through a number of these tools, but the first two I do really want to call out. The first one is the participation status lookup tool. This is where you can go to our website, enter in your 10-digit NPI, and it will tell you whether or not you are eligible, whether or not you're excluded, if you have special statuses, and that basically tells you, so if you're eligible, which clinics you are associated with for being eligible. If you are excluded, so if you're excluded, that means you don't have to participate in the program. If you are eligible but you have a special status, that could mean that, for example, you may be part of a small practice. So one of the things that we've taken a particular focus on is the additional challenges that small practices may face. So if you have a special status, it's actually a good thing because that means that you get special scoring consideration. So this changes annually, again, because the participation criteria and what we ask you to do, it is an annual program. So again, highly encourage everyone to go to our website, enter your NPI, and see what your status is. If you are an administrator for your organization, we do have the ability where you can log into our website and request that eligibility information for all of your clinicians as part of your practice. So again, if you are an administrator in a 1,000-person practice, doing that for each and every NPI could be a bit of a hassle. So we do have the ability for you to extract that for all of your NPIs. The other tool I really want to call out is the Explore Measures tool. So again, for each of the 4 performance categories, there is a certain amount of flexibility on what you have to do based off of your specialty and or the way that your practice is set up. So we have the ability for you to sort and figure out which measures and activities would apply to you. Okay, so eligibility basics. So how do we determine if you actually have to do the MIPS program? So first we check to see whether or not you are an eligible clinician type, and then otherwise if you would be excluded. So let me actually skip this slide for a second. So MIPS eligible clinicians, and you'll hear me talk about clinicians rather than just saying physicians, because we include both physicians and non-physicians. So the eligible clinicians for this 3rd year include physicians, PAs, NPs, CNSs, CRNAs, psychologists, PTs, OTs, pathologists, audiologists, dietitians, nutrition professionals. When I talk about physicians under Medicare, I don't just mean MDs and DOs. Medicare by law includes in the physician definition chiropractors, optometrists, dentists, and podiatrists. So a bit broader definition of a physician than what many of us would think of. So if you are, or if your organization has these clinicians as a part of it, they could be eligible. Then what we do is we look to see, would you otherwise be excluded? So the basic ways that you can be excluded are 3 main areas. The first is if you become newly enrolled in Medicare. So this would be when you receive your NPI and you initially enroll in the PACO system. So again, after you or your clinicians have completed their residency, they have their NPIs, they're no longer billing associated with the attending. Again, when the clinician initially enrolls in Medicare's PACO system, so for that 1st year, the clinician would be excluded. So if someone, again, enrolls later this year, July, August, that means that for this performance period, 2019, they're excluded. They would, however, conceivably be eligible in the following year unless they would be excluded due to the low volume threshold or participating in an APM. For significant participation in an APM, again, that's that 2nd track of the QPP program. And this is if you meet certain thresholds of participation. Most of the APMs actually have this defined as part of the APM themselves. So we do have this information already available, again, as part of that lookup tool I was talking about. And then the second exemption, I will be spending a fair amount of time talking about because it has changed over the initial couple of years. So let me go ahead and start talking through this. So the low volume threshold. So the low volume threshold exclusion is a way that as a clinician, you can be excluded if you don't meet or exceed 3 elements. So the first is the total amount of billings that you do, which for this 3rd year is 90,000. The second is the total number of patients that you see. Again, for this 3rd year, that would be 200 patients. And then the 3rd item that we look at is the number of services that you render. And we look for 200 services. So to be eligible, again, first you would have to be one of those eligible clinician types. So you would have to be, for example, a physician. Then you would, for your Medicare patient population, bill more than 90,000 annually, see more than 200 patients, and render more than 200 services. A lot of times I get asked, what's the difference between a patient and a service? When you think about your patients and how they can come and see you multiple times throughout the year. So again, if I'm a doctor and if I see a patient, Let's see, that patient comes in to see me 6 times throughout the course of the year. That one patient would count as a 1 towards my patient count, but the 6 separate times that they come in and see me would count as 6 services towards my services count. So again, if you exceed all 3 of these, and again, if you are that eligible clinician type, so again, if you are a cardiologist and you bill $150,000 a year, you see 500 patients, you render 1,000 services, you are eligible for the program. This information is also baked into that participation lookup tool. So again, we've tried to take the guesswork out of it because I recognize it can be really difficult to try to track for each and every single one of your clinicians what was the total amount of billings that they did. So we newly added that in this year, and we did that because we wanted to account for instances where maybe you don't have 200 patients, but you do meet that services threshold. So I think I actually have it in an upcoming slide. So I will come back to that. So just the timeframes that we look at. So it's not on a calendar year, it's on a fiscal year. We look at it on the fiscal year because, again, we feel that it's important to try to share with you guys as much information as we can ahead of the performance period or start of the performance period of what you have to do. So our initial look, again, for the 2019 year was the fiscal year that ran from October 17th through September 30th, 18. Then we have our second determination period, which runs from October 18th through September 30th, 19. If you are excluded during the initial run, so if you only bill $50,000 annually, you only see 50 patients, you only have 50 services, and if that changes in this most recent fiscal year, let's say your billings and your patient population doubles or triples, you would still remain excluded. What we found from our initial years of experience of the program is that making that change so late in the year can really negatively impact folks, so that's why we do that. So it does differ if your organization decides to participate as an individual or as a group. So under the MIPS program, you can participate as an individual based off of your unique TIN MPI or as part of a group. The group is defined as the TIN and all the NPIs associated with it. So we recently released just last week our first year's experience under the program, and we found that I think it was around over 80% of folks actually participated as a group. It makes sense for a lot of large multi-specialty practices. Again, when you think of an organization with 1 TIN and 1,000 or more NPIs, trying to corral and organize all of the NPIs to try to select different individual measures. I definitely can understand the concerns and burden there. So what we do is we look to determine whether or not you would be eligible either as an individual or as a group. So again, if you go to that lookup tool, you can see how it's broken down, and you could be excluded as an individual, but you also could be eligible as a group. That's pretty common. So what that means is if as an individual, let's say you fall below that low volume threshold, you only bill $50,000 annually, 50 patients. If your organization decides to participate for each and every one of you as individuals, you would continue to be excluded from the program. If your organization, however, decides to participate as a group, and if you are eligible as a group, then you as the clinician should contribute to the performance of that organization. So again, these are decisions that you all should be having with your practice administration to really determine how you all would want to participate. What we saw, again, we just have our first years of experience with us to date, so we're still working through our second year. What we typically are seeing is that for those organizations that think they're going to do well, they do decide to participate as a group. Or if we are seeing smaller practices or solo specialty practices, they may be participating as a group. Otherwise, some people are participating as individuals. But again, it's completely up to you all, you as clinicians and as part of your organization. Yes. Okay. And then, so for your question of why did we add in that services criteria? So one of the things that we heard from the first year of the program is that you could be excluded, but you still want to participate. And so what existed in the first 2 years before we added in that services was the only way you could participate is to volunteer. And so when you volunteer, that means that you are not technically a MIPS eligible clinician. It means that you are excluded. You are just participating. I don't want to say for fun, but I mean, it could be for fun. So you're participating for whatever your personal reasons are that you are deciding to participate. It could be that you know that you're going to be eligible in a future year, and so you want to kind of get a sense of how the program works. But what that means is that if you're not eligible, you would not be getting that payment adjustment, whether that positive adjustment or the negative adjustment. So it's kind of risk-free participation. But what we heard is that there were some people who maybe they were excluded based off of the amount of billing and the number of patients, but they could have been eligible if we didn't look at all of those items and looked at their services. So that's why we added in that third criteria, the services criteria, because if you, and I don't have that slide with me. So if you meet one or two of those low volume threshold criteria, I can hop back, but not all three, you can choose to opt in. So the common example is if you meet or exceed the dollar amount. So let's say, for example, you have $100,000 in billing annually. You only see 100 patients, but you render 250 services. So what that would mean is that you would be a opt-in eligible clinician. So that means that you as a clinician, or conceivably your organization, but what we're seeing thus far, it seems to really be applying to people that are participating as individuals, you would have a choice on whether or not you want to participate or if you want to remain excluded. Again, if you remain excluded, that means that you are not a MIPS eligible clinician. You won't get any money, whether it's more money or less money. If you decide to participate and opt in, that means that you become a MIPS eligible clinician. And again, you could get that more money on your reimbursements or less money if you do not have a final score at or above 30 points. We're still working through the way that you all would actually communicate this to us. We are actually undergoing user testing right now. We want to make sure that the way that people have to tell us this isn't extremely burdensome or complicated. So again, that's why we haven't given details yet on exactly how you will tell us this. But since we're just going through that user testing now and designing it, I anticipate we'll be able to share those details in the coming months. One thing to keep in mind, and we did talk about this in our rule that we issued last year, is that once you make that decision to become opt-in eligible, you want to be a MIPS eligible clinician, and you communicate that to us, you can't take it back. It is irrevocable. So it's, again, just something you're going to want to think about. But again, more information will be coming out on that. There is information currently in our lookup tool for you or your clinicians on who would actually be opt-in eligible.
Irrevocable for that year?
Correct. Yes. Yeah. So everything happens on an annual basis. Okay. And then this I touched on earlier. So if you're associated with multiple practices in the lookup tool, this would be, again, if you have multiple distinct 10 MPI combinations. And so it is pretty common. What we've seen is that, if you do the majority of your services, you see the majority of your patients at a given clinic, you could very well be eligible for that clinic. For the clinic that maybe you only work at 1 day a week or, a weekend a month, you probably wouldn't actually exceed that low volume threshold. But again, things to keep in mind are how your organization has chosen to participate in the program. what we're seeing, again, for the majority of the larger organizations, they all are making these decisions and then, communicating it down to the rest of their clinician team. Okay, those are the eligibility basics. Any other eligibility, well, not that you can't ask me questions later, but any other eligibility questions before I move on to start talking through what you actually have to do? Okay, so I've already talked through some of this, so the options on how you can participate. So I've already talked about the first two. So as an individual, again, your unique TIN MPI. As a group, that is a TIN where 2 or more MPIs, you've reassigned your billing rights over to the group. The other way you could participate is as part of a virtual group. This is something, again, MACRA, the law, tells us to do. And so this is specific to solo practitioners and groups with 10 or fewer clinicians. If you want to virtually come together as a group just for MIPS purposes, by law, you have to tell us that you want to do that before the performance period begins. So for year 3, 2019, we're already past that time. If this is something that you or your organization may be interested in for year 4, which would begin in calendar year 2020, we would just need to know by December 31st of 2019. So if it's something you're interested in, again, we already have a lot of information on our website of the specific requirements and what that would look like. Okay, some other key terms to know, and let me actually just go ahead and jump to this slide here. So again, I've been talking about ways that you can participate as an individual versus as a group. So are any of you guys familiar with the legacy programs, the PQRS program or value modifier? Somewhat? Okay. So one of the concepts that you probably heard us talk about under those programs was the usage of a registry. And so we talked about under the old PQRS program, a registry both as the way that you as a clinician can work with a registry to submit data on your behalf to me, CMS. We also talk about registry-specific measures, and then there's also the registry, the organization themselves. So I'm going to go ahead and pick on ACC, American College of Cardiology. They've been one of our registries for many, many years. So one of the things that we found when we transitioned from those old legacy programs to the new program was that we actually, our product team, and by working with all of you, by doing our user experience testing, we've been able to design a better system than we actually thought we could have. So the way that we talked about things under the old programs was a lot more restrictive than what it actually is. So the main distinctions here is really in this quality row. So as you can see, as individuals, we have submission type, submitter type, collection type. So this refers to different ways that you as an individual, and I have the subsequent slide which deals with groups, which I'll come back to that, that you can choose to get your data into us and how you can participate. So if, for example, as an individual, you want to work with, let's say you're a cardiologist, you want to work with the American College of Cardiology to have your specialty-specific measures and also have them submit your data, you can go ahead and do that. So that would be looking at our options here. It would be either direct or login and upload, working with a third-party intermediary, either using the MIPS CQMs or the QCDR measures. The direct submission type deals with the ability for certain organizations to directly send us data. So this is using an API, an automated programming interface. So we found that a number of organizations have this technical capability. It wasn't something we had originally really conceived that organizations would want to do, but we heard really loud and clear from our first year that a number of organizations have this ability and want to send us that information directly. So if your organization has the ability to do that, you don't have to work with a third-party intermediary. A couple other things to note for individuals and groups, and again, for those of you that are familiar with the legacy programs, so you'll see under quality the Medicare Part B claims. That's for small practices only. So that's where, for quality, you would append a quality data code or a G code on a specific claim. That's only available for small practices. we define small practices as 15 or fewer clinicians associated with a single TIN. So if you are a small practice, you can do that. If you are not a small practice, you cannot report on the Medicare Part B claims. We also still have our web interface option. Again, this is really popular amongst groups. This is where there's a beneficiary assignment sample for a certain set of measures where the group would go in and report that performance information for each of the patients up to the sample. Okay. So those are kind of the basic ways of how you can participate, how you can get your data in. So let me start talking through the performance periods and then the 4 performance categories. So I've been talking about the performance period of 2019. So that is true for quality and cost. And the reason why we ask for quality and cost clinicians to do that on a 12-month period is, again, one of the things we're really focused on is improving patient outcomes. And so we have been increasing the number of outcome-based measures that we have as part of our measurement portfolio. As you guys know, to really see those improvements in the patient's health, a lot of times those measures require either a look back or look forward period or a separate action to occur. When the performance period is less than 12 months, it doesn't really give enough time for that outcome to be achieved. So it's really to the benefit to have a longer performance period. For cost, again, it's 12 months when you look at those measures and those activities there to really be able to to meet the minimum sample size required, to get the reliability threshold we're looking for. We really need it to be on a 12-month period. Cost, we calculate all of that on our own. Improvement activities promoting interoperability. When you look at those activities and actions, it has to be completed for a 90-day period. If it's easier for you all to go ahead and do it for the full 12 months, you can always do that, but a minimum 90 days is all that's required for improvement activities and promoting interoperability. For the weights, again, I mentioned this earlier. Again, as you can see, all of these sum up to 100 points. A couple things that I do want to note is in some instances, we may not be able to calculate cost for everyone. So if that occurs, those 15 points that are allocated for cost, they don't go away. Those 15 points get redistributed to quality. This is something the law tells us to do. I didn't come up with this. So if you are a type of clinician where we can't assess cost for, so again, cost would not contribute towards your final score, quality would get a higher weight. We also see for a number of folks promoting interoperability, again, that's the category that deals with EHR usage, where either it gets automatically reweighted or you can request a reweighting exception. So it gets automatically reweighted if, for example, you are a nurse practitioner. Those 25 points automatically go towards quality. If, however, you are a nurse practitioner, you are participating as an individual, you want to go ahead and send us your data for promoting interoperability, then that reweighting would get canceled out. So kind of the key takeaway here is that your performance is always going to be based off of a total number of 100 points. If for some reason we can't calculate a performance category, it generally always gets redistributed to quality. So talking through what we're actually asking you to do in each of the performance categories. So for quality, what we're asking you to do is to select 6 measures. One of those needs to be an outcome measure. If for whatever reason there's an outcome measure that doesn't apply to you, you would need to select another high priority measure. High priority measures include, of course, outcome, care coordination, patient experience, patient safety, appropriate use, efficiency, and we also newly added in this year opioid-related measures due to the opioid epidemic. If in scenarios there are not 6 measures that apply to you, we would look to see how many measures you actually could have reported on and then base your performance off of those 6 or however many measures there are. You can select those measures either so you can go to our measure lookup tool, which I talked about earlier. You can select it by looking through our 257 measures. You can keyword search. You can just have a fun day looking through all 250 measures if you want to. We also have the ability for you to sort and filter those by specialty. So we have a number of specialty-specific measure sets available as well. We've actually worked with all of the specialty associations to develop those sets so they make sense for your specialty. For each of the measures, so generally your performance can range between 1 and 10 points. We create a historic benchmark based off of data that's available to us by 2 years prior. So we've already issued our benchmarks for the 2019 year. They're on our website now. They're broken down by decile marks. So what that means is that we calculate the performance benchmark and break it down into decile breaks, which can range from 1 to 10 points. So let's say, for example, a measure, it's a relatively new measure. Let's say there hasn't been a lot of performance on it. So the decile breaks could look like, to get the maximum number of 9 to 10 points, your performance would need to range between 72% to 100%. So it really will depend for each measure where the decile break is. But again, those are available now. You can take a look at those for your selected measures. You can see where the performance rates are, so you can get a sense of, okay, if I want to try to get the maximum number of points, this is where my performance would need to range. Or, you know, if I just want to get to the middle spot, this is where my performance would need to be at. Just one second. There are a couple of other things I want to talk about for the measure benchmarks and the scoring. We do have bonus points that are available. So for each measure, you can get bonus points. You can get bonus points if you report on additional outcome measures than the first required one. So again, remember, for that 6 measures, 1 has to be outcome. If you do 2 measures, 2 outcome measures, the first one's required, the second one you get bonus points for. The same would happen, again, for other high priority measures. Again, the kind of thought behind this is that we really want to try to incentivize folks to work on more patient outcome measures, as well as those patient experience, safety, appropriate use, opioid-related measures. We also have bonus points, if you submit your data in an end-to-end fashion using your certified EHR technology. Again, focusing on interoperability is a huge focus of this administration. There was a recently released interoperability rule that Administrator Verma talked about a few months ago. We also have bonus points available if you are part of a small practice. So again, if your organization has 15 or fewer clinicians, if you report on 1 quality measure, you get 6 bonus points towards quality. So this slide is pretty important. So if you do nothing, that means, so the law had a lot of great things in it. Well, it had a lot of things in it. One of the things that it also told us specifically that we have to do is that if your final score is in the lowest quartile related to the performance threshold, by law, you have to get that maximum negative adjustment. So again, if you do nothing and you're eligible, that means, and even if everybody else in the country does nothing, so, you know, let's say 95% of everyone who's eligible, they just don't do anything. So, you know, there could be a lot of money that we could give to the positive people. But if everybody doesn't do anything, all of those people would have a 0 final score, which means you would get, I don't know if this has a pointy thing, I don't know. You would get the negative adjustment of 7%. So that means on your $50 reimbursement, whatever negative 7% is off of that. I can't do math. So we want to avoid that as much as possible. Once you go into the other kind of ranges, so the 7.5 to 30, as well as above the 30 to upwards towards 75%, then that's the sliding scale. So if your final score ranges somewhere between 7.5 and right below 30, you'll be getting a negative adjustment, but it could range anywhere between negative 0.01 to negative 7%. Again, really depending upon what the total number of people are that are getting the negative versus positive. The same can happen on the positive side. So again, if the different situation happened where 95% of people performed at or above 30 points. So then the total amount of positive adjustments we could give could be well below that 7%. So quality, again, it can be around 10 points per measure. Data completeness. This deals with the total amount of patients that you actually report on. So for year 3, it's 60%. So basically what I'm asking you to do is that for your measures you've selected, you need to actually report on those measures for 60% of your patients, both for Medicare as well as the non-Medicare payers. If you don't meet data completeness, that means that the maximum number of points you can get is 1 instead of 10. The exception is that if you're part of a small practice, then you get 3 points. So again, what we're trying to incentivize is that you actually are reporting and doing these measures on your patients. Okay, let me try to talk through the rest of the categories relatively quickly. Cost, 15 points. No separate reporting you have to do. We calculate all of this in-house at CMS. We will calculate your performance on, we'll try to do it for the Medicare spending per beneficiary measure, a total per capita cost measure, and then 8 episode-based measures, which are on this slide here. If in scenarios we cannot calculate your performance on these 8 episodes, or for the MSPB or total per capita cost measure, again, these 15 points that are allocated for cost get redistributed to quality. So then quality, instead of counting for 45 points, would count for 60 points towards your final score. If you are let's say, a hospital-based clinician, where, let's say, we can't calculate cost for you, we also can't calculate promoting interoperability. Then what your score would look like is quality would be worth 85 points, improvement activities would be worth 15 points. Again, if you go to that participation lookup tool I talked about, it should have baked into it your special statuses, so you can see what, again, you actually have to do for you as the clinician. Okay, improvement activities. This deals with quality improvement. There's over 100 activities to select from. The key piece you want to keep in mind here is that you want to do the appropriate number of activities to get to 40. Medium activities count for 10 points. High activities count for 20 points. If all you have to do is select one, attest to doing it by saying yes to us. So a few examples of, I think, the common ones that we saw last year were expanded practice access, so after-hours care. I think I saw a high number of people completing CME. There's a number of other activities that we have available. If you have a special status, so looking at this bottom blurb here, if you're part of a small practice, if you are in a rural or HIPSA area, if you're non-patient facing. Non-patient facing means that you would be a pathologist, anesthesiologist, certain types of radiologists, and nuclear medicine, you get double weighted. So remember, I mentioned at the beginning, if you have a special status, it's a good thing because you get some extra scoring considerations. So what this means is that if you're a part of a small practice, you could just do one high-weighted activity and be done. Okay? Promoting interoperability. This is the category that deals with certified EHR technology. So for those of you who remember the old Meaningful Use program, this is this is a much better version of that. So in this year, you have to use 2015 edition certified EHR technology. Your cert has to be updated to 2015 edition by the last day of the performance period. So I get asked that question all the time. So if you don't have 2015 edition cert right now, you just have to make sure that it gets upgraded by the end of the year. We did an overhaul of this performance category based off of folks' feedback to really focus it on a distinct set of objectives and measures. This also aligns with changes we've made into the hospital promoting interoperability program. So to have that alignment, that was a common complaint that we heard, was that when MACRA passed, there wasn't that alignment anymore between what we asked people to do with their cert under the hospitals versus clinicians. So again, focusing on e-prescribing, health information exchange, provider-to-patient exchange, public health and clinical data exchange. There's a number of measures. In some instances, actually in many instances, there are exclusions for the measures. In those instances, the points associated with the measure can get redistributed to another measure or activity. So what you have to do the promoting interoperability performance category, again, if this applies to you, is, again, have 2015 edition cert and have it or use it for 90 days or greater. Then there's a number of attestations you have to say that, yes, you've done this. So the first is that you did an information block, that you would comply with ONC direct review, and that you completed the security risk analysis measure. These measures sometimes will just ask for a simple yes or no, did you do it? And other times we actually want to see the performance rate, so it differs measure by measure. And then this is the reweighting I had been talking about. So the left-hand side, the automatic reweighting, these are the ones where we just do this on our own. The only scenario where we actually would assess promoting interoperability for you is if, again, for example, you're a hospital-based clinician and we receive promoting interoperability performance category data. But if you're a hospital-based clinician, you don't want to deal with certify, or you don't want to deal with promoting interoperability, those 25 points would be weighted in quality. For the application-based reweighting, so what you have to do here around the summer, we announced the reweighting timeframe opens. I think last year we opened it either in I can't remember if it was June, July, or August, so sometime in the summer. You have until the end of the year to request a hardship reweighting, and so these are some of the scenarios on why you can request that. Okay, I'm right at time. Let me just quickly go through the rest of these. I think I've already talked through most of this, so the 30-point threshold. So let's come back to this slide. So I think the one piece I haven't talked about, which is on here, is the 75-point piece. So this is if you are an exceptional performer. So you are already we don't actually say great performer, but I can call you a great performer if your if your final score is at or above 30 points. You are an exceptional performer if your final score is at or above 75 points. And what that means is not only would you get the MIPS adjustment, but Congress gave us a separate bucket of $500 million we can distribute annually to exceptional performers in the first 6 years of the program. So if your final score is at or above 75 points, you can not only get the adjustment, the money you could receive as part of the MIPS payment adjustment, again, subject to that scaling factor, the winners and losers, but you could also get an extra bonus if you are that exceptional performer. So we really want to try to encourage as many people to try to hit that threshold as we can. I think that's the main pieces. We have a lot of resources, support, and help available, which is all on this slide here. Let me stop for any other questions, and I know I'm at time, so I apologize for cutting into your lunch hour.